What the Study Says.
Welcome back to What the Study Says. I'm Dr. Kai.
And I'm Dr. May.
Let's be honest. It's a topic most of us would rather avoid at a dinner party, right?
Definitely.
Yet it impacts millions and can seriously affect quality of life. Today, we're taking a deep dive into something surprisingly common, often painful, and let's face it, definitely not glamorous: hemorrhoids.
Indeed. While they might be the subject of a few jokes, for approximately 10 million individuals in the U.S. alone, hemorrhoidal disease is a very real, very uncomfortable pathology.
10 million, wow.
Yeah. So our mission for you today is to unpack the very latest insights from, well, a really authoritative source, the medical journal JAMA. Specifically, their comprehensive 2025 review article authored by Jean H. Ashburn, MD. We're going to navigate its findings on epidemiology, pathophysiology, diagnosis, treatment, basically give you the essential knowledge without the overwhelm.
Okay, let's do it. And maybe cut through some confusion right away. When we say hemorrhoids, we often think about the problem.
Right.
But the truth is, hemorrhoids are actually completely normal structures in the anal canal. We all have them.
Exactly. Think of them like specialized cushions, vascular tissue, connective tissue. They're supposed to be there.
So the issue isn't having them, it's when they become symptomatic, pathological.
Precisely. That's when we call it hemorrhoidal disease, and it's not just some minor complaint.
No, the numbers are huge. It's the fourth leading outpatient gastrointestinal diagnosis in the U.S.
Accounts for 4 million annual ambulatory care visits.
4 million. And $1.3 billion in annual healthcare spending. That's significant.
It absolutely is. And while it's, rarely life-threatening, the impact on a person's daily quality of life can be profound.
We're talking about things like bleeding.
Bleeding, that intense itching pruritus, rectal pain, pressure, sometimes a sensation of tissue prolapse. It's really uncomfortable.
But here's a crucial point you mentioned in the review. Asymptomatic hemorrhoidal disease doesn't require treatment.
That's key. If these normal tissues aren't causing any problems, you don't need to do anything about them. No need to fix what isn't broken, essentially.
A really vital distinction.
Yeah.
Okay, so let's explore the why and who, the epidemiology and the risk factors. Getting precise numbers seems tricky.
It is because, well, understandably, many people avoid seeking care, or sometimes they get misdiagnosed. But historical data gives us a sense of how widespread it is. A U.S. survey back in 1989 estimated 36 million adults, that's like 20% of the population, then had a diagnosis.
20%.
And 7.7 million had undergone a surgical procedure. More recently, a study found hemorrhoids in 38% of people undergoing colonoscopy.
So if you've experienced this, you are definitely not alone.
Not at all. And what's interesting is that some things people think are risk factors, like heavy lifting or family history.
Yeah.
Well, they aren't actually very well studied. The evidence supporting them is pretty limited, according to this JAMA review.
Okay, so what does have strong evidence?
Pregnancy is a big one. A prospective study showed 43.2% of pregnant women developed hemorrhoidal disease.
Wow, nearly half.
Mostly in the third trimester. And the risk factors within pregnancy included things like having prior hemorrhoids or fissures, constipation, straining over 20 minutes during delivery.
Right, the pushing.
Exactly. And even newborn weight over 3,800 grams. But the good news for new mothers is that these issues often resolve on their own after delivery.
That makes sense, given the physical stresses involved. It sounds like our bowel habits play a huge role, too. You mentioned constipation.
Oh, absolutely. Constipation shows a particularly strong association. Patients with hemorrhoidal disease report more straining, that feeling of incomplete emptying hard stools. In fact, a greater proportion of these patients met the Rome-I criteria for constipation. That's, things like straining during at least a quarter of bowel movements, lumpy or hard stools, feeling like you haven't quite finished.
So frequent straining is a definite red flag. What's also fascinating is how seemingly unrelated conditions can impact this area, like cirrhosis.
Yes, the review highlights that. In patients with cirrhosis and portal hypertension, you can get anorectal varices, enlarged veins, which can look like or even coexist with hemorrhoids.
They're different things.
They are. Varices tend to be bluish, non-prolapsing veins. Hemorrhoids are softer, reddish-purple swollen veins. But the connection is that patients with cirrhosis and portal hypertension have a much higher prevalence of hemorrhoids, around 59%.
Nearly 60%. It's a reminder that you really need a proper diagnosis.
Exactly. And it's not just constipation and cirrhosis. Some studies link diarrhea to hemorrhoids too, sometimes alongside conditions like colitis or intestinal malabsorption.
So extremes at either end, basically. Too hard or too loose.
It seems that way, yeah. Both can contribute.
Okay, so we've covered what they are and who gets them. Now let's maybe peel back the layers on the anatomy. Where do they actually come from? Can you walk us through the structure and classification?
Sure. So as we said, hemorrhoids are these normal cushions of vascular and connective tissue in the anal canal. They actually help with continence, surprisingly, and protect the sphincter.
Right.
The key landmark, the sort of dividing line, is called the dentate line. It's about 3 to 4 centimeters inside the anal opening.
Okay, the dentate line. And that divides them.
Exactly. Above this line, you have internal hemorrhoids. They're covered with columnar epithelium that's like gut lining tissue. They contribute to resting anal tone, helping prevent leakage. When these become diseased, their support structure weakens. They get engorged, they bleed, and crucially, they can start to prolapse, meaning they slide down into or even out of the anal canal.
And below that line.
Below the dentate line, you find external hemorrhoids. These are covered with squamous epithelium, which is basically skin. And here's the critical difference. They have lots of nerve endings from the pudendal nerves.
So that's why they hurt.
That's exactly why they hurt. Normally, they might just cause some painless swelling. But if a vein inside thrombosis forms a blood clot, that's when you get acute, sharp, severe pain. Often looks like a firm, bluish-purple lump.
Ouch.
Yeah. And sometimes, after the clot resolves, it can leave behind a little skin tag. And of course, you can have mixed hemorrhoids, which are a combination of both internal and external.
So it's not just inside or out, but really a difference in tissue type and nerve supply. That completely explains the different symptoms. Internal ones often cause that painless bleeding.
Right, blood on the stool, dripping in the toilet.
But less pain. Maybe some discomfort and that prolapse issue, which is graded I to IV based on how far they come out.
And that prolapse can cause wetness, itching from mucus. Rarely, if they get trapped outside, strangulation can occur, which is very painful.
Whereas the external ones, if thrombosed, give you that sudden sharp pain. The bluish lump.
Exactly. Pain is usually the main complaint there, though they can bleed if the clot erodes through.
Okay. Given these varied, sometimes overlapping symptoms, getting an accurate diagnosis sounds absolutely critical. What should you expect when you see a clinician?
Well, patient history is paramount. A good clinician will ask about the specifics of your symptoms, frequency, severity, but also about your diet, water intake, toileting habits like straining. This helps differentiate it from other things like sharp burning pain after a bowel movement might suggest an anal fissure.
Right.
Bleeding that happens without a bowel movement or finding a palpable mass could be a red flag for something more serious like anorectal cancer. And that JAMA review mentioned a study. Quite sobering.
Yeah.
Only 50% of patients who came in saying, I have hemorrhoids, actually had diseased hemorrhoidal tissue. Half the time, it was something else.
Wow, 50%. That just hammers home the need for a professional diagnosis. It's not just about comfort, it's about ruling out serious stuff.
Precisely. So the physical exam usually involves looking at the outside, a digital rectal exam to check muscle tone, and then anoscopy to actually look inside the anal canal if symptoms aren't clear.
And sometimes a colonoscopy.
Yes, that might be recommended, especially if there's a family history of colorectal cancer or unexplained changes in bowel habits, abdominal pain, or bleeding that isn't clearly from down there, like blood mixed in the stool or iron deficiency anemia.
Because other things can coexist, right?
Exactly. Hemorrhoids can exist alongside other problems, including adenomas or even cancer, so a thorough check is vital.
Okay. So message received, don't self-diagnose. Get it checked out properly. Let's move on to relief. What are the treatment and management strategies highlighted in the JAMA article?
The philosophy is always start least invasive. And as we keep saying, if they're not causing symptoms, no treatment needed.
Right. So first up is conservative management. First line for pretty much everyone. This seems heavily focused on diet and lifestyle.
Absolutely. The biggest things are increasing fiber aim for 20 to 30 grams a day and drinking more water, maybe 5 to 6 glasses daily. This softens the stool, makes it easier to pass, less straining.
Less straining is key.
Totally. The review even mentioned a TONE program, T-O-N-E, stands for aiming for 3 minutes to defecate, once a day, no straining, enough fiber. Simple, right?
Sounds simple. Did it work?
A study found it actually improved prolapse and bleeding. Fiber itself is great for reducing bleeding, but the review notes it doesn't seem to do much for prolapse, pain, or itching on its own.
Interesting. What about sitz baths? Lots of people recommend those.
Yeah, they're commonly recommended soaking the area in warm water. They can feel soothing, provide some comfort, but interestingly, the evidence that they actually reduce pain is quite limited.
So maybe more comfort than cure.
Seems that way. So simple changes at home can make a difference, especially with those bathroom habits, but when that's not enough.
Then we move on to medical therapy. Often topical things, right? Creams, suppositories.
Yes. Creams, suppositories, astringents, lots available over the counter or by prescription. Topical hydrocortisone is a really common one. They're low risk, can give temporary relief for mild symptoms, maybe help you avoid procedures by calming things down.
And then there are things called phlebotonics. What are those?
Phlebotonics like flavonoids, calcium dobesilate are medications thought to improve vein tone, reduce capillary leakage. They might help with itching, bleeding, leakage, overall symptoms, but they aren't great for complete pain relief. And the recurrence rate after stopping them can be pretty high, maybe 80% within a few months. So more for symptom management than a long-term fix.
Okay, so if conservative and medical steps aren't cutting it, especially for those internal ones, grades 1 to 3, then we look at office-based procedures.
Exactly. These are a step up, but often avoid full surgery. And the first one, often recommended by guidelines, is rubber band ligation, or RBL.
RBL, how does that work?
It's actually quite clever. A small elastic band is placed around the base of the hemorrhoid above that dentate line to minimize pain.
Ah, above the nerve-rich area.
Right. It cuts off blood flow. The tissue then necrosis, shrivels, and falls off in about 1 to 2 weeks. Leaves behind scar tissue that helps anchor things.
And how effective is it?
Pretty effective. Resolves symptoms in about 89% of patients, though maybe 20% might need a repeat banding later. Long-term, one study showed 86.7% symptom-free at 8 weeks, but about 15.5% recurrence at 2 years. It also works well for mixed hemorrhoids.
Sounds like a solid option. Any downsides or complications?
There can be. Complication rates range from 3% to 23%. Rectal pain is the most common, about 16%. Bleeding happens in roughly 3%.
Okay.
And the bleeding risk is higher if you're on anticoagulants, like maybe 25% risk for warfarin users versus less than 3% for others. And very rarely a serious complication like pelvic sepsis can occur. Needs immediate attention.
So RBL, effective, but important to know about potential pain and bleeding, especially with blood thinners. What about other office procedures? Injection sclerotherapy.
Sclerotherapy involves injecting a solution to cause scarring. Fibrosis. It generally causes less post-procedure pain than RBL.
That's a plus.
But it's also less effective than RBL for controlling bleeding and prolapse. Good short-term results may be 70–85%, but long-term remission only in about a third of patients.
And infrared coagulation, IRC.
IRC uses heat to coagulate the tissue. Success rates around 70–80% for bleeding and prolapse. But studies suggest more patients treated with IRC end up needing more interventions later compared to RBL.
So it really seems like RBL is often the preferred first-line procedure, balancing effectiveness and recurrence, even if there's a bit more discomfort initially for some.
That seems to be the takeaway from the evidence, yes. But options exist if minimizing initial pain is the top priority for someone.
Okay. Now, what about those acutely painful thrombosed external hemorrhoids?
Yeah.
The sudden ones.
Right. For those, timing is key. If you get to a clinician within 72 hours of it starting, and in-office clot evacuation is often recommended, just removing the clot, it significantly reduces pain and recurrence risk.
And if it's been longer than 72 hours?
Then conservative management is usually preferred stool softeners, pain relief, oral or topical sitz baths. It provides relief, but maybe doesn't prevent recurrence, as well as early clot removal.
So acting fast really helps with that acute pain and reduces future issues.
It does. The data shows surgical treatment resolves symptoms way faster, like 4 days versus 24 days with conservative management, and cuts recurrence from about 25% down to 6%.
Big difference. Okay, finally, for the severe cases, grade 3 internal extensive mixed hemorrhoids, or when other things fail, we get to surgery. The main one is excisional hemorrhoidectomy.
Yes, that's often considered the first-line surgical treatment. It involves removing the abnormal hemorrhoidal tissue under anesthesia, can be open or closed technique.
And the outcomes?
Very good long-term outcomes. Low recurrence rates, maybe 10%. It's definitely more effective than RBL for grade 3 disease. Fewer repeat treatments needed.
But the recovery sounds like the tough part.
That's the trade-off. Recovery takes longer, typically 9 to 14 days. And potential downsides include significant post-operative pain, can be severe bleeding in about 6%, urinary retention, especially in men, and sometimes issues with fecal incontinence, which can be transient or rarely persistent.
Okay, so effective but a significant recovery. Are there less invasive surgical options?
Yes, there's transanal hemorrhoidal dearterialization, or THD. It's minimally invasive. They use ultrasound to find the arteries feeding the hemorrhoids and ligate them, tie them off without actually removing tissue.
Cutting off the supply.
Exactly. The big advantage is less pain compared to the excisional surgery. Patients generally need fewer pain meds.
But effectiveness?
That's the downside. Higher recurrence rates, especially for prolapse. One study showed 59% recurrence at a year compared to 31% for excisional surgery. So again, it's that careful dance between effectiveness, recovery, side effects. A conversation to have with your surgeon.
What a comprehensive overview of the options. So, wrapping this up, what's the big picture takeaway for our listeners from this JAMA deep dive?
I think the critical thing to understand is the sheer public health impact. This is incredibly common, it really affects quality of life, and it costs a lot. But the good news is there's a clear step-by-step approach to manage it effectively if you're having symptoms.
Exactly. So our key takeaways for you listening are, first, don't ignore persistent symptoms like bleeding. But also remember, not all hemorrhoids need treatment if they aren't bothering you.
Right.
Many cases, especially early on, can be managed really well with those simple lifestyle changes. Fiber, water, not straining.
Absolutely. That's foundational.
If those aren't enough, effective office procedures like rubber band ligation are available and often the next best step. And for severe or complex cases, surgical options offer good long-term results, even though the recovery needs careful consideration.
And the most critical piece, get an accurate diagnosis from a clinician. Rule out other things, understand the treatment ladder. That empowers you to have a better conversation with your doctor.
Absolutely. So maybe the provocative thought to leave you with today is this. While hemorrhoids might be a silent struggle for so many, they're really not an unsolvable problem. Perhaps the real challenge isn't the condition itself, but maybe our reluctance to talk about it openly and seek care when we need it. What do you think? Is it time we stopped suffering in silence?
I think so. Your health is definitely worth talking about, and your comfort matters. Thank you all for joining us for this crucial deep dive into the latest from JAMA. If you found this information valuable, please make sure to subscribe to what the study says.
Yeah, and share this deep dive with anyone you think might benefit. We love bringing you these insights.
Your support really helps us continue doing this.
Until next time, stay curious and stay informed.